which is a signature surgery we developed, pioneered here at Deuk Spine Institute to treat pain from a herniated disc, whether it's in the neck, we call that the cervical spine, the lower back, lumbar spine, or the thoracic spine. There are far fewer herniated discs that cause pain in the thoracic spine because the thoracic spine is stabilized by the ribs. So the cervical spine or neck and the lower back, lumbar spine, are the most common areas of the spine to have painful discs that are injured. Now, for a disc to cause pain, it has to be injured first. And the injury is something called a disc herniation. Let's scroll it. So we're doing 4-5-5-1, right approach 4-5, left approach 5-1. Scroll it. Now, I don't decide what surgery I'm doing in the operating room. I always decide before we get to the operating room. And by the time we get to the operating room, we already know what we're doing. So I don't do things on the fly. Our patient is awake. Good morning, are you okay? Yes. Dr. Deuk here. We're going to get started, okay? Now, you might feel a little poke. If you do, just lay still and say, ouch, and I'll give you some more medicine, okay? Don't try to get up off the table, move your head, move around, all right? You're on an operating table. You're strapped in, but I don't want you to fall off. Got it? So lay still, okay? If you feel a poke, say, ouch. Now, if it goes down your leg, like a sharp pain down your leg, say, ouch, my leg. If it's just in your back, say, ouch, my back, okay? All right. And I'm going to put you to sleep, but not just yet, okay? So this is the left side. This is L5-S1, correct? Everybody agree? And we have a pseudo disc or fake disc at S1, S2, okay? That's my hand pushing on you, okay? You'll feel a little stick and burn. That's just the numbing medicine going in. Don't be alarmed. I apologize. There's no way to make the numbing medicine not painful. Isn't that funny how we create pain to take pain away? I apologize. Same thing on the other side, okay? I apologize. I'm so sorry. It's just a quick sting. It should feel better in just a minute, okay? I used to mark everything out. 7 cc's injected. I stopped doing that because marking out just, honestly, it took more time, plus, more importantly, it didn't really help. Okay, num. So I'm going to start on the patient's left, which we know is the L5-S1. I can feel the fascial membrane of the dorsal fascia. That is a pain-sensitive structure. All right, let's get a shot. So let's go lateral. Would you say most of your pain is back pain or down your leg? How much is back pain versus leg pain? Wow. Okay, no problem. I'm not trying to put you on the spot. I'm just asking.
I get confused whether it's my back pain or my diabetes.
No, but diabetes doesn't cause back pain. Ever. Well, pain down your leg would be like a sharp shooting pain down your leg. Sciatica, basically. All right. So, folks, you can see there's a pseudo disc, S1, S2, and then there's a disc that the needle is next to. It's actually a facet joint, but just in front of that is a disc. So I hope you're working on getting us a little bit better picture. I like your L5 pedicle. I don't know that that's the right move there, Jordan. I think it's more of a wag, just a slight wag. Because look at the pedicle of S1.
Thank you very much. Thank you. No, no, you can.
The S1 pedicles have a slight double shadow, which means they're slightly wagged out. We need to try to improve that just a little bit. You're almost good. So the disc in front of the needle there, folks, is white. And that's it. No, it got worse. Yeah, maybe the other way. Right, Monica? We're not far off, guys. We're not far off. So we're talking about 1 or 2 degrees. You know, that's doable right there. Let's just work with that. I like that. Okay. Shot? All right. So, remember not to move, okay? I think we're off just a little bit now. I don't know what happened, if it's him or you guys. Shot?
Gary. One more, I think, please.
Shot? Feeling the facet joint. Shot? Yeah, understood. Shot? Shot? Trying to gain access to 5-1. Shot? Shot? Yeah.
Toe.
Your toe.
Yeah.
Okay. Which side?
Left.
Let's go AP. See where we are. I apologize. Still there?
No.
Okay. Mm-hmm. Let's go back to a lateral view. And this is the 5-1. I mean, it looks pretty good. But still bothering you in your toe? Huh? If you can help me interpret what he's saying. Right. It's not bothering your toe now? Right? Okay. You feel what? Uh-huh. All right. Well, this is the help I need from you. So you're doing a great job of giving me that information I need. Let's get another shot. All right. So once again, folks, we have a little bit of rotational abnormality. I wonder, let's just try arcing and seeing if it makes it any better. It may not. I'm not going to do anything until you try it. I just want to see. I mean, it almost looks like the pedicle there, right? We're looking down the barrel of the pedicle, a 5. Don't you agree, Monica? See it in the middle of the other pedicle? So go the other way. Why are my hands tingling? You got me the right size gloves?
Yeah, 8.5. You want a 9?
That's better. Right there, that's better. That's probably as good as we're going to get it, to be honest with you. Let's just keep it there. That makes a difference. Shot? I may need the 9. Don't know yet.
Gary, can we have a
Shot?
over here, stand by? 9.
Where do you feel that?
I don't know.
Shot? You don't feel it down your leg, though.
No.
That's a facet.
Lately, like in my back.
Yes, sir. Yeah, that's where you're supposed to feel it. Where there? Back? Shot?
Back and a little bit of toe.
Anything here? No?
Oh, yeah, there.
AP. So the needle looks perfect on the lateral view. Now the question is, on the AP view, is it going to look perfect as well? Remember, we're trying to sneak in under the nerve root. I can see the pedicles. There's a double shadow. I know the nerve root is way above me. Yeah, way above me. You see that? The nerve root's coming out at the pedicle of 5. So if you look at the needle tip and you go up, there's a round structure. That's the pedicle of 5. The nerve root comes out there. So we should be way below that nerve root. And we're nowhere near the traversing root. Back to a lateral, please. Just lay still. We're almost done. This is the hardest level to get to, okay? So once we get into this one, we're good. You're not having any pain down your leg, correct? Okay, we got a drape is caught here. There. All right. There we go. Good. Where? In your back or down your leg?
I don't know, it's say both.
How far down your leg?
I can't tell. Right there, hit my toe.
The question is, I mean, we're so far below the nerve. Is it still bothering your toe?
Yes, it's a little bit. Not as sharp, but just kind of a
Is
dull.
it getting better? You don't need to take a picture yet. Is it getting better?
Yeah.
You feel it in your back at all?
Yeah, I feel pressure. That's okay.
I'm trying to figure out if he's getting his radicular symptom from him just tightening up. Still? Yeah. All right. Let's get another view, another shot. Give me another shot. All right. So we just got some rotation. Let's try to get the S1 superior end plate better. And I think we need to do some orbiting to get the S1. Are you still having it in your foot or not? No. The other way. What do you think, Monica? It's better, huh? Yeah. All right. Shot? Oh, I think we're hitting the end plate of S1. Shot? 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 Where do you have it? Okay. We're right in the area of your bad disc, so we're making progress. Shot? We're almost done torturing you. I want to get you to sleep, but I can't put you to sleep just yet. Shot? Huh? Yeah. Really? Hmm. Operating without medicine. I love it. No, we are using medicine. Trust me.
I mean, the young lady, she's slacking.
The anesthesiologist.
Yeah.
Oh yeah, no, we want to put you to sleep, but we can't because I need your help.
Yeah, I've done that.
And you are definitely helping me, sir. No doubt about it. You're doing your job. Try to relax your back a little bit. I know it's hard. Shot. Mm-hmm. You still getting that leg pain?
A little bit of coke and just a little sharp every once in a while.
All right, shot. Let's get an AP. All right, so it's been difficult to get into 5-1 as always, but in his case, he's got some scoliosis at 5 and S1 between the L5 and the S1. You can see it right there. And we're kind of rubbing up against the end plate. So I'm happy where we are. I think it's good, but I think we can do a little bit better. So not trying to gild the lily, but I do want to be as good as we can get it. So I'm trying to use the needle's natural curve to find the right spot. Yeah. And, oh yeah, the patient is uncomfortable. So what's happening is he's clamping down on that disc. So I need to find out if I'm in the disc and confirm that. And there's a way to do that besides using x-ray. Are you comfortable?
Yeah.
All right, well, let's see. Shot. Shot. He's so collapsed there. We're definitely in the disc. But I think we're buried against the end plate. So. Shot. I pulled it back just a little bit. We're in the disc. Did he get any medicine? How bad was that on a scale of 1 to 10? What's the worst it got? How bad? 10. All right. So we just did the discogram at L5S1. I did it early. Sorry about that, okay?
Yeah.
By the way, my name's Dr. Patel, in case you're upset. Just kidding. I'm just kidding. It's Duke Majan. Duke Majan. I take credit for making you hurt. I just didn't, you're a big guy, so I don't want you coming and finding me. So if you want to hunt anybody down, it's Dr. Patel, okay? All right. So I got good news for you. You felt that pain, right?
Yeah.
That was a 10 out of 10. Is that your typical back pain?
Yeah.
So that's the L5S1 disc, one of the ones that we're repairing, okay? And we found the source of your pain. It's that disc. I'm going to fix it for you. And when you wake up, the pain will be gone.
Good.
But I'm not ready to put you to sleep yet, okay?
More pain, man.
Well, just hang in there for just a few more minutes. Yeah. I got to get to the other side. But I already numbed it up pretty good, so hopefully it won't be as uncomfortable for you. Okay? All right, so I'm feeling the fascia. I'm on the right side. So just to verify, I'm going to look at my consent once again. And on the right side, which is now where we're going to 4-5, L4-5. So it was a left 5-1, which we already did, and it's a right 4-5. So why do we do that? Sorry about that. We do that in patients who have pain down both legs. You have to treat both sides. So I have to figure out which disc is causing right-sided pain, which disc is causing left-sided pain. You know you bleed blue. Did you know that? Yeah, I'm just joking with you. I don't mean Democrat blue, I mean Duke spine blue. All right, lateral. No, I didn't mean Joe Biden blue. I meant Duke spine blue. Oh my God, don't get those two confused. I'm a Republican as well.
Good.
I need a lateral. Yeah. I don't talk politics though when I do these broadcasts, and I'm not going to start today. But I think we need to be a little bit lower. You're doing great, and I apologize, it's uncomfortable. But you're doing really a good job. That's perfect right there. I think we could have it. I mean, the L4 pedicles are perfect. The end plate of 4 is good. I think we're good right there. Let me just try to get this to work, okay? Shot? So part of the problem is your spine is twisted, okay? Your spine is rotated. Shot? And we're not doing anything about that. To fix that, we'd have to do a fusion, which we're not doing. Shot? So I'm up against the facet. I'm pretty good aligned with the disc. I may have to go a little higher, actually. I may have to, because of this disc. Because the 4 is slipping forward on the 5. I may have to get to it from being, I already numbed it up. You can see with the wheel. Let's try to get the pedicle of 5 lined up a little better. It's a wag issue. We're almost there. It's only about a degree or 2. I think that's worse. Let's try the other way. Just a little bit. I think that's better. Yeah, it looks like I need to come from up. So, all right. You're going to be happy when this is all done. Unfortunately, it's a little uncomfortable for the time being. Needle. All right. So, my trajectory, I'm not happy with being lower. So I'm going to have to come from a higher trajectory. Shot. That's better. Huh? What is it? Shot. You're doing great, and I apologize. We're almost going to put you to sleep. I just need you awake for a few more minutes. Shot. Huh? What'd you say? Shot? Yeah, he has anterolisthesis. For sure. Anterolisthesis grade 1 at 4 on 5. Where do you feel that, Shot? Yes, sir. Okay, just about done. Where do you feel that, Shot? All right, we're almost done. Just bear with me. Try not to move. We're almost done. Okay, you're doing fantastic. Shot? Shot? Yeah, we're just about there, sir. I promise. Hang in there just another minute, and we'll be done. Shot? Uh-huh. Shot? Where do you feel that, Shot? AP? I think we're okay. Just want to verify that on the AP. Yeah, I know. No pain down your leg, right, this time? No. All right. So, would you say most of your pain before surgery was back pain?
Yeah, it was buttocks.
Yeah, back and buttock, but I mean, as opposed to down your leg. You had to walk with what, sir? Like a penguin. All right. Are you comfortable? How bad is that on a scale of 1 to 10?
Right on all the way.
10.
Yeah.
All right. Okay, we tested both discs. They're both 10 out of 10 pain. So that pain you felt, is that your typical daily pain?
No, we heard a lot worse.
Well, I know it's more intense, but is the location where you normally get pain?
Yeah.
Yeah, so that pain will be gone. And as long as you don't do anything you're not supposed to do after surgery. Follow my restrictions. That pain will go away for the rest of your life, okay? We're going to put you to sleep, and when you wake up, we'll be done. You made it through the hard part, okay? Yeah, just start counting from 1 to 100 out loud for me. Let's go back to a lateral, please. Okay, in Latin. Yeah, just a little bit. Okay, so at this point we've got access to both annular tears, herniations, and one on the left is at L5S1, the one on the right is L45. Why do we do it that way? Because I believe the L5S1 disc herniation is causing his left leg pain. And you could see as I was going into the disc, he had pain down his left leg. That's because as I got to the annulus where it's painful, it caused the pain he typically gets. He tightened his back muscles and it compressed on the disc and pushed some of the disc out against the nerve. So then on the right side, I believe his right 4-5 herniation is causing his right leg pain and back pain. Okay, we'll start with the L5S1. We're going to place our guide wire. And now we're at L5S1. I need a lateral view. Okay, good. Now this is the tough one because I couldn't get the needle in any further because I hit the end plate of S1. Shot? And that's okay. I just need to make sure that it stays in there. Let's go ahead and do the incision. So we use an 11 blade. Our patient is a large man, like physically large. So he's got a big back. There's more soft tissues. And it's deeper. So we should be able to do this shot. I want to make sure the guide wire stays in place, and it is. Now it's real important at this point. The anesthesiologist needs to help me, which he is. Obviously with the blood pressure, but also with his pain. If the patient's in a lot of pain, as I'm doing this step right now, they're going to clamp down on their disc. And that's going to make it impossible for me to get the dilator in. So I need to communicate with her, shot, and make sure she feels he's ready for some stimulation, we call it. Is he? Okay. Shot. So I'm basically just working my way down, and it's so nice that he's not jumping around everywhere. Shot? Can you give me a better picture? Just, yeah, it's almost good. It's almost perfect. I want to see if I can make it just a little bit better. I don't think that helped. Whatever you did, go back. Let me have that. All right, so I'm going to advance the dilator. I feel very comfortable. We're in the right spot. I'm going to need to use the other hand. Shot. Shot. So I need to just be careful. I want to lose my guide wire, and I don't want to misdirect my instrument. Shot. Right now that trajectory looks pretty good. Shot. Yeah, just slowly trying to work around my, so the guide wire didn't go in as far, right, as we've done in the past, because I'm kind of, that's good, take that, all right, because I couldn't get the needle into the disc very far. Shot? Not yet. Okay, not yet. Shot? There she blows. There she blows. course, it's supposed to be there she blows, mighty. And what are they referring to? Anybody? No, that's land ho. There she blows. What animal blows? Whales. Why would the pirates care about whales? Or why would the captains of ships care about whales? Well, yeah. If they were whaling. All right. But also sometimes they'd follow the whales, migration patterns. When you're out at sea, everything looks the same. Can I proceed? But whales, they have an internal navigation system. They know exactly where they're going. And if you follow the whales, you can get somewhere you need to go based on the whale's migration pattern, right? Is that it?
Yes, sir.
All right, so we need to go a little further. Shot. Beautiful. Doctor, I love the amount of pain control we're getting here. It's perfect. Because I'm able to get this instrument into the disc, which is very painful, obviously, for the patient, which is why he needs to be asleep. But that said, he's not clamping down, preventing me from getting it in, which means you've got him perfectly controlled with breathing and pain control, which is not easy to do, folks. Not easy to do. You're welcome. Give credit where credit is due. All right, shot. We're inside the disc at L5S1. It's beautiful. We can get rid of the fluoro, and you guys can see what I'm doing. So, I know I'm in the right spot. As I said, there's a pseudo-disc or fake disc below us. We call it the S1, S2 pseudodisc. By the way, it's very important to take note of that, because treating the right disc on an MRI versus using an X-ray in the operating room to navigate, on one hand you're using the MRI to navigate, the other hand you're using an X-ray to navigate. Two very different imaging modalities. One is radiation, the other one is magnetic. So in the operating room, that's what we use to navigate. And you need to know when you have a fake disc or pseudo disc that you're not treating, and factor that into your localization. All right. So here we are getting ready to do this Deuk laser disc repair on the left side at L5S1. And our camera is in position. You can see inside, and there's a little schmutz on the lens I'm going to wipe off. It's probably just air bubbles. All right, thank you, Luis. Now, we just bought travel suitcases for our equipment. So if anybody wants us to travel to where you are to do your surgery, just let me know. I will warn you, though, it is expensive to fly my entire team and all of our equipment. So it may be more cost effective to come to Florida. Besides, if you come to Florida for your Deuk laser disc repair, for your herniated disc, you can go to Disneyland, Universal Studios. What's amazing to me is that Disney stock has not dropped from this COVID. I mean, it had one bump down because I was going to buy some, but it's still too high, so I'm not buying it. But you'd think COVID would have a massive effect on Disney stock. I guess, laser on, I guess it doesn't, which I'm happy for Disney and the stockholders. All right, there's a little air bubble there. Try to jiggle it away, which I successfully did. We are inside the L5S1 disc, and I am using the laser. The blue tube, the blue thing, is the laser fiber. It is not the laser machine. There's a machine in the operating room right over here to my right that is the size of a large suitcase, a very expensive suitcase, and it is the laser generator. It basically creates the energy beam, the laser beam, that travels along this blue tube about 6 feet away, and I direct this laser beam right into this tube, right down to the disc herniation, and I use it to debride the annular tear. So, is there a laser necessary for this surgery? 100%. If you go back and watch all my surgeries I've done, over the last 15 years I've been doing this surgery, I have never not used the laser. As a matter of fact, I've done over 1,200 of these surgeries, and in 1,200 you'll see the laser. Why? Because it's absolutely the best tool to use for this application, for this procedure. There is no other tool that's better. There is no other tool that can even come close to doing what this laser is doing right now. As a matter of fact, any other tool would not work and would not get the results that we get with the Deuk laser disc repair, which is basically elimination of pain. Is our last patient ready to go yet? She should be. I don't want her to leave until I come say hi, which I'll be there in about 15 minutes. Oh, this is tight. So it is tight. I got to pull this tube back, but it is tight. And that's because this disc is collapsed. And that's because the bones on either side, you can see the pink bone there is the bottom of the L5, and the pink bone there is the top of the S1. This is the L5 S1 disc, okay? It is literally, his muscles are attached to the bones. So the muscles are squeezing the bones together at the disc. And whenever the patient feels a little bit of pain, he gets a little squeezy with his muscles. They contract. And by contracting, they squeeze my tube between the bones and lock it in. I've even had a patient once crush my tube. That's how powerful the muscles are. Crush the tube. Right, Louise?
Yes, sir. Yeah.
That's a $1,200 tube. That's a $1,200 shake straw. So I had to spend $1,200 to buy a new one. I never charge the patient because it's not right to do that. I just paid for it myself. But long story short, I can't afford to crush tubes.
We have a question.
I'm so happy there's a question. Yes, this is the annular tear I'm debriding, by the way. This is the signature hallmark of the Deuk laser disc repair. No other surgery in the world does this. Yes.
We have a viewer from Facebook wondering, how do you deal with osteophytes that cause foraminal stenosis?
How do you deal with osteophytes that cause foraminal stenosis? Great question. See that right there? That is an osteophyte. And that's how I deal with it. I zap it. This area right here is osteophyte. We're going to get it. We're going to get it. Just watch. Here's a little bit of fat. It loves to billow out. And what's causing it to billow out is essentially the pressure wave that the laser creates. So osteophytes, I have found, rarely cause significant foraminal stenosis. But when they do, you use the laser on them. See all this down here? That's an osteophyte. Goodbye. The osteophyte has no chance against the laser. That would be like hot knife versus butter. Who's going to win? The hot knife. The laser wins every time. This laser can melt steel, and it does melt steel. If you look at some of my tubes, right over here, you'll see little etches on the steel. And that is from the laser hitting the steel and melting it. Each burst of this laser can melt the steel. There's a piece of herniation. Come on out and say hello. That's one of my kaijus. Okay? Okay? That's the disc kaiju. Remember, we're in the breach. Did I answer that question there, Sean? This is a bone spur right here. See this? All this stuff right here was a big bone spur sticking out. It's just gone. And the truth is, we're not here to get rid of bone spurs unless they're causing symptoms. So I'm not going to say, all right, guys and gals, let's stay here and hit every bone spur we can see. That's stupid. We don't want to do that. That would be not beneficial to the patient, not beneficial to anybody. So we only want to get rid of bone spurs that are causing pinching of nerves. And you can see very easily the laser is perfectly capable of removing bone spurs. All right, we're just about done here. believe it or not, that all that pain this patient's had for years and years and years is going to be gone with this simple procedure, this simple little surgery that nobody else knows how to do. For some reason, even though I've been broadcasting it for 7 years, free, for the entire world to watch. I don't hide any of it, for God's sakes. And yet, all these stupid spine surgeons just ignore it. I'm sorry, but they are, folks. Do I sound like an angry man, resentful? Huh? Sometimes, Louise says. I am angry because their arrogance prevents them from accepting a new reality. Anyway, and ultimately patients suffer, okay? Because people they don't get the right care they need to get better, and that bothers me. But I'm just one voice of millions. I can't make a loud enough sound. We did a play once in high school called The Mouse That Roared. The Mouse That Roared. And it's about a tiny little country that nobody paid attention to, a voice they never heard, they didn't even know existed, and then one day it roared, and everybody found out who it was. So, hear me roar. This is the cure to back and neck pain, thoracic pain, and we need more doctors doing this procedure, the Deuk laser disc repair, okay? And I can't magically make that happen. And for those of you who think I can, you're wrong. Standby laser. The only way this is going to happen is for people like you. Hey, I'm not done. What do they call that? Jumping the gun? All right, there's the nerve. Finally, we get to see a nerve. Okay, right there, that white thing. That's the bottom of it, in the foramen. It's still got a little bit of tissue around it. Let me see the laser. Maybe able to get a better view of it. But this is right where the dorsal root ganglia is, by the way, for those of you who know what that is. It's the part of the nerve that has the cell bodies of the sensory nerves that carry pain, right? And of course, it's right near the annular tear. What does that tell you? Hello, McFly. There's a connection. The annular tear full of inflammation right next to the dorsal root ganglion. So it's easy to have radicular symptoms with an annular tear. Standby laser. All right, let's see if we can see it once again. There's some epidural veins. It's still hidden in the fat. Oh well. And anyway, that's where the herniated disc was. It's gone now, okay? So we're done with 5-1. Oh, I forgot to suck it out. Want to suck that water and juice out. Pretty cool. Water works. All right. Can you all see this here, Sean?
Yes, we can.
So, just to orient you, the middle of the back is right here, the line, and the butt crack is here. This hips, pelvic hips, and this is our left L5S1 incision, which we're removing our endoscopic tube, and we got our incision there. And again, a few drops of blood, that's all. So you're looking at a surgery that has the highest success rate of any treatments in the world for curing disc pain from a herniated disc, degenerated disc. You're looking at a surgery that has the smallest amount of blood loss of any real surgery and the fastest recovery. There's absolutely nothing bad about the Deuk laser disc repair except that it's only done here in Melbourne, Florida, so you have to travel. That's the only bad thing about it. And of course it's bad for the implant companies. They don't get to sell screws and rods. And it's bad for the insurance companies because they have to pay for it. All right, let's get this in and let's get going.
You want to switch
Yeah, I'm going to come on that side. I just want to apply some pressure. Why don't you come around? So what do you got for lunch, Sean? Pizza?
Yes, it's pizza.
All right. I'm going to switch around to the other side because that's the kind of guy I am. Thank you. That's perfect. Thanks. All right. So Luis is applying pressure to the patient's left. What's going on here? Meanwhile, I'm going to start the right side. This is the 045 shot. Nice. I can feel the guide wire in the disc. We're coming out of the disc. Shot. Leaving the guide wire in. Perfect. You can see there is a listhesis at 4.5. You guys need to clean that 4.5 up. I would drop your fluoro and I would wag it so you get it right. Okay? Incision number 2. So can the surgery be done at hospitals? No. Why not? Because hospitals don't have this equipment. They don't. All right, we got to do better than that. Drop your fluoro to the ground, which you have you done? All right, raise your table up an inch. And then let's see what we can do there. Let's see. Take a shot. I don't know. Maybe it's got to be like a not a wag issue, but a rotational issue maybe. Just a little bit, maybe 2 degrees. I just feel like we're looking obliquely. That's better for sure. I like that. I can deal with that. All right. So you can see there's a listhesis of 4 on 5, and here we come. Has anyone ever tried whistling with a surgical mask on? I mean, everyone's been wearing masks because it's COVID time. But have anyone ever tried whistling? How many people can whistle with a mask on? All right, we got one over there, a whistler. Anybody else try it? Sean? Thoughts? Strategies?
I can,
You can whistle with a mask on?
as long as it's not too tight.
All right, fair enough. All right. It's a good fact to know. I'm just advancing the dilator. Shot. All right, so I want to follow my guide wire. A weird thing is I feel like I'm at the back of the disc. It's such a deformed area that it's really hard to tell. But I'm feeling at the end of the dilator shot pressure. Now, there we go. That's beautiful. We're entering the disc itself along the guide wire shot. This is the more stimulating part. Shot. I feel us passing through the tear. I can feel the tear. Yep. I think I'm done with my guide wire. I may want to advance the dilator a little bit more just to make sure it's in there good. Shot. You don't want that thing popping out, right? Well, okay, so can you all see this, Sean? Eye in the sky?
Yes.
This is, we do the entire Deuk laser disc repair endoscopic transforaminal surgery with this little metal straw, okay? We're going to do everything through that little opening. This is not a percutaneous surgery. It's a real surgery. It's not done through a needle. It's done surgically with an incision. It's just done with a tubular retractor arthroscopically. Hold on. Shot. Let's see where it is. I don't think we're far enough down. Let's see what I can do here. Shot. Well, interesting. Let's have a cotton. Let's have a Raytec. Yeah, I don't want to bend these metal tines. Shot. I felt it go there. That was good. Shot. All right, almost there. Shot. Yeah. All right, there we are. Just need 1 more millimeter. Take it. Let's see. So I'm going to line this guy up here. And that should do the trick. Shot. Trying not to advance my dilator, only the tube. I don't want the dilator going in anymore. Shot. Dilator's perfect. But I do need to advance the tube. Shot without advancing the dilator. So I'm sorry if the sight of me banging something into somebody bothers you, but that's surgery. Yeah, it shouldn't bother you. Don't let it bother you. Understand, shot, in the end, we're fixing a human being's pain. So it's all for good. The good of man and womankind. All right? You should be pulling it back as you're doing that, not just one movement at a time. One movement at a time is for protozoans, bacteria. Even they move in multi-direction. Humans can multitask. Okay. This should be our second and final disc, the L45. Once again, we're inside the disc. That is nuclear material, nucleus pulposus. It's stained blue because it's degenerated. It's been injured, and it's now has been acted on by the inflammatory process. So all those macrophages and neutrophils releasing their chemicals onto these tissues over years and years has caused the disc nucleus material to degenerate, and it allows the dye that I use to bind degenerated nucleus. Okay, the blue dye. That's the blue I was talking about earlier. Not Democrat Republican blue, but Deuk spine blue. That's perfect. Thank you. The colors of Deuk Spine Institute are royal blue and gold, in case you're wondering. If you're a fan of racing, motorsports, you've probably seen the Deuk Spine Institute logo as our premier driver, Arias Deukmajian, my son, has traveled around the world racing, primarily go-karts, but soon to be cars, and promoting the brand, the Deuk Spine Institute brand, making people aware, hopefully, that back pain can be cured, neck pain can be cured, thoracic pain can be cured. You just need the right diagnosis and the right treatment. Okie dokie, here is our tear. You can see the white stuff is the annulus fibrosus. It's very scarred up. It's got some calcification of it. That's what the gold color is. And I am just cleaning it up, debriding it. Now this looks very different than the last disc. The last disc was far more degenerated and collapsed. This disc is still juicy and plump, but it's got a lot more scar tissue. You see all that? White stuff is scar tissue from chronic inflammation. Chronic inflammation produces scar tissue. It produces scar tissue. That's why if you have an injury to your joint or a muscle or your skin and it doesn't heal quickly, it produces scar tissue, a lot of it, and that's a problem, especially if it's in your piriformis muscle. You know, you get a buildup of scar tissue in your muscle, and it's every time you move, it rips the scar tissue a little bit, causes more pain. So the treatment of pain really needs to focus on the treatment of inflammation. And my advice to anybody in pain is figure out why you're in pain by going to the right doctor or educating yourself enough to diagnose your source, and then laser, and then treating the inflammation causing the pain quickly. Even if you have an infection causing your pain, it's still due to inflammation. The infection itself causes the inflammation. Even if you have a fracture causing your pain, it's still due to inflammation. Inflammation from the fracture. Okay? The vast majority of pain in the neck and back, chronic pain, doesn't come from fractures, infections, or even tumors. It comes from joints that are damaged and inflamed. Okay? Those are your disc joints or your facet joints. And that's what we fix here at Deuk Spine Institute. So spread the word. If you care about other people, let them know. It can be cured. They don't have to live with chronic back pain or neck pain. They just need to go to the right place to get fixed. We have patients traveling all over the world to Deuk Spine Institute to get their back pain or neck pain cured. This is a big, thick wad of scar tissue, by the way. You see all the white stuff? Mm-hmm. All right. How's our last patient doing? I had asked. She's ready to go or what? All right. I want to see her before she leaves. Mm-hmm. Thank you. So I entered this disc kind of on the low side. Oh, they say that good surgeons played video games when they were younger. It's true. I played a lot of video games, and I don't play them as much as I used to because I don't have time. But I used to make time and play a lot of video games. And I think it really does help with hand-eye coordination to do the surgery right. Plus you get the level bosses. And these herniations are kind of like level bosses you got to beat, right? Anyone not know what a level boss is? Anyone? Anyone? Bueller? Bueller? Huh? The big guy at the end of the level. That's right. That's exactly what a level boss is. I'm so happy you know that. Give that man a raise. Just kidding. Huh? Zelda. No. Every video game. Doom, Quake, all of them. They all have level bosses. Unreal. All the OG first-person shooters. Look at that tear. Look at the herniation. It's the reverse herniation we described at Deuk Spine, where the herniation comes back into the disc, because that's where we are. We're inside the disc. That's the tear, by the way, in case you didn't see it. Just rewind. And this is the tear we have to fix in order to get rid of the back pain. You see, it's a much more well-developed tear in this disc. In the L5S1 disc, it's pretty much gone. I mean, mostly gone. It was just, over time, just destroyed, the whole disc from the inflammation. Sean, any questions from our all-knowing audience?
None so far.
Anyone know the term for all-knowing? Omniscient. Very good. I love it. Little trivia. All right, so we are just about done. I need 5 minutes and we'll be done. Let me grab that little piece of disc out. Okay, I'm just pulling the tube back, getting to the outer fibers of the annular tear. Just about done. Patient's doing great. Not even a peep. Why is it some anesthesiologists can manage this so well and others have such a hard time? Huh? Do you know? Experience. It's more than that. It's more than experience. Because I have anesthesiologists with more experience than you that have been here and they've practiced longer and the patients are suffering during the whole procedure. So it's not just experience. Okay, it's more than that. And the same thing about surgeons. You have surgeons with greater experience than me and their outcomes are horrendous compared to mine. It's more than experience. I really think it has to do with caring. Caring and analysis and wanting to do better, wanting to be the best at what you do, wanting to do your job the best that you can possibly do it. And then having the intelligence to be able to self-analyze what you've done wrong and how to fix it, prevent it from happening in the future. It's professionalism. Really what it comes down to. Damn it. Get that garbage out of there. Okay, you can see the tear right there. Just about done. It's taken a little longer at this disc because the tear has got more scar tissue, it's more developed. There's the granulation tissue. The most painful part of the tear is always on the outside of the disc, the outer annular fibers. That's where the blood supply is. Remember, the disc itself is a relatively avascular structure. It doesn't have any blood supply to the inner part of the disc, the nucleus, and the blood supply is only to the outer half of the annulus fibrosus. Now, of course, that's with a normal anatomy disc, but once you've injured your disc and you have a tear in the annulus, the granulation tissue will grow all the way from the outside to the inside. Why am I having, are we have enough fluids, irrigation? Seems like it's struggling to clear out the debris. Are you happy? Do we have enough? Yes, sir. All right, so there's an osteophyte on the end plate. I don't have any flow, okay? I don't know what you're doing over there, but I don't have any flow here. There's a little bit. Are you getting?
Don't blow the back, but
Yeah, that's better. Whatever you did, it's better. We good? I only need another minute. I had an anesthesiologist once who had been practicing for about 40 years, and he was here doing the anesthesia, and I swear every patient he did, the patient was awake the whole surgery, oohing and awing, and I never used him again. But he, you know, he felt, of course, it was safer for the patients to be less sedated, which, I don't know, maybe it is, arguably so, but yeah, well, but you don't want their heart racing because then they're going to get a angina, you know, as you know, they don't get good perfusion when their heart's beating so fast because they're in pain. So you could actually cause a heart attack by not giving the patients enough, you know. Yeah. So the patients came to me afterwards the next day and they said, you know, I was awake for most of that surgery. I said no, because they weren't moaning and groaning, so I don't know if they're awake or not, unless they tell me. Either that or they didn't give enough amnestic agent. So, yeah, it's possible. Either way, they had a bad experience. They all complained. So,
Not what we're here for.
no. I think your patients are going to do fantastic. Can already tell. Just about done. 10 seconds.
Gary. 4x4, steady speed.
All right, laser off.
So take it there, please.
Just a little bit of blood, no big deal. Again, it's tiny. Looking good. All right.
Lights on, please.
So I'm going to just suck all the cold irrigation out. Scope off. All right, if you have questions you want me to answer about this surgery or any type of spine problem, whether it's what causes pain or anything to do with the spine, happy to do it. Just type it up and I'll be over there in a minute, okay? And we'll answer those questions. Once again, we did the incisions on both sides for this patient because they had bilateral leg symptoms. Normally I would just treat one side, but everybody's a little different. All right. Good work, everybody. Let me go. Sean, I'll be there in just a minute, okay?
All right, everyone, we're back again for the post-op Q&A. Dr. Deuk is coming into the room now. He's going to be sitting down with us shortly to answer any of your remaining questions. If you do have any thoughts or questions left, go ahead and type them up in the chat now. Otherwise, I'll be handing the microphone over to Dr. Deuk to go over and recap the surgery you just watched.
All right. Apologize for the light in the background. We're going to work on that. So we just finished Deuk laser disc repair, L45, L5S1, opposite sides. Our patient is a gentleman who's had chronic back pain for years and pain down into both legs. We got the needles and the guide wire in position through the foramen on both sides. Eventually got the scope in and was able to find the tears in the back of the disc that were causing his pain. We confirmed that he had pain. It was 10 out of 10 pain at L45 and 10 out of 10 pain at L5S1 when I did the provocative discogram. The discogram is a very useful test to figure out if a disc is indeed causing back pain that the patient typically has, and it was for both of these discs. Patient is getting out of the operating room. We'll be able to go home soon. Now, our first patient that we did this morning, she had the L45, L5S1 done as well. And she is ready to go. Her back pain is completely gone. She's not on any pain medication. The medication we use to put patients to sleep is called propofol. IV propofol does not stop pain. It only puts people to sleep. But once they wake up, whatever pain they're having, they're still going to feel. So propofol is not a pain medication. It's only a sedative. And so we're going to go see her right now. We're going to end this broadcast, and we're going to start the post-op broadcast for the first laser surgery we did today. Do we have any questions? All right, join us in about 5